Assalamu alaikum and good morning, everyone. Welcome to Monday morning virtual Grand Round. Today, Grand Round topic is management of COVID-19, a practical guide. Objectives of this lecture are to present latest national and international data and stats related to COVID-19, to discuss evidence-based literature on treatment modalities of COVID-19. So I invite today's speaker, Dr. Faisal Mahmood. Dr. Faisal Mahmood is Associate Professor and Section Head, Infectious Diseases, Department of Medicine. So over to you, Dr. Faisal. Hello.
Yeah, sorry, you muted and I unmuted you, and then I say Assalamualaikum. So first of all, apologies. I promised myself I will not do a COVID grand round because इतने सारे COVID grand round हो चुके हैं that I was like कि अब तो थक गए होंगे सब लोग. मगर a couple of things changed actually. One is that we refinalized the national guidelines about 2-3 weeks ago, which has some changes in it. And the other thing is, I was in the COVID unit, and I realized, we've seen a lot more depth of patients. So I thought it'd be good to review the practice guidelines. Magar ye wale jo hai, the presentation is not going to be like the previous ones looking at treatment, because the goal is going to be slightly different. So because I'm going to review the current guidelines, both for diagnosis, classification, and therapeutics, and that's going to be the first half of the talk, and then we'll do some interactive cases. And these are real cases. Most of these are currently admitted in the hospital, and this will give you a little bit of a feel of what sort of patient is seeing, and give you a chance to be part of the care, hopefully, and see how we can really apply the guidelines. What I won't talk about is investigational therapies we don't have available over here. So it'll be a little less theoretical and more practical in terms of how would you manage COVID patients, both in the inpatient, outpatient, and some in the ICU also. Shuru ki cheeze revision hai, but things have changed also. So diagnosis ke andar, we know that our clinical criteria have shifted because our epidemic has been evolving over time. And jaise we have more and more cases, some of our classic risk factors, jaise ki travel ho gaya, are really no longer relevant anymore. And the other thing we realized is that symptoms can be very, very subtle. So we can have people who have sore throat and nothing else. And so we really need to have a high suspicion now, especially today. The rates are really high. And to give you an example, if you look at the national rates, 1 in 3 patients with COVID are detected in Karachi at this point. So Karachi really is an epicenter. We're in the middle of really the epidemic at this point. But if you travel ki baat karta hai ki kaise aaya hai, I usually tell them that the bigger risk is being in Karachi as opposed to coming to Karachi at this point. Which means that agar ye criteria which I'm going to go over, if they don't fulfill, you may still consider testing in them if the suspicion is high. So what are the current criteria? So even if you look at respiratory symptoms alone, somebody needs to mute. Which is the cough or shortness of breath and difficulty. So you would probably warrant testing. The other way to look at it is if you have other symptoms, and usually we say 2 of these symptoms, which would be fever, repeated shaking with chills. And interestingly, we've seen a number of patients now who don't have fever, but they have chills only. Myalgias, headaches, sore throat, and a new loss of taste or smell. So any of 2 of these. But again, we've had a couple of patients who've only had a very mild sore throat and have also turned positive. So this is a good guide for you to sort of decide agar test bhejna ki nahi bhejna. And because tests are still a little limited, we have prioritized them. So the high priority tests are those patients who are inpatient currently. Healthcare workers always are high priority because obviously of the risk of spreading. People who live in a congregation, this would be prisons, shelters, hostels, madrasas, and who have symptoms. And then finally, those who have an X-ray which look like it could be COVID, even agar aapke koi symptom nahi hai, bahut atypical say symptoms hai. And then we give priority to outpatients with these symptoms, healthcare workers who may not have symptoms but have exposure to a patient. And then people who have been exposed to COVID patients. So you can see there's no low priority anymore. It's either high priority or just a priority of diagnosis. Everybody we try to test. Gold standard अभी भी PCR ही है. This is the way that we test. But the other thing that's changed from maybe even a month ago is that the sensitivity of the PCR, we would say, would be like 60% or 70%. So we've become a lot better at doing the PCR, or the PCR has become better actually. And really the sensitivity now depends कि आपने sample कौन सा लिया है, because now we know there are more than one ways of taking the sample. And this is from the IDSA guidelines for testing, which is a really great document worth having a look at. But this is just one small table from it looking at sensitivity specificity. And you can see the oral swab has a lower sensitivity, but very high specificity. While the nasal swab, now we're not saying nasopharyngeal, this is just sif naka, andar ka naka, the sensitivity was higher at 76%. But interestingly, when they looked at the nasopharyngeal swab, their sensitivity was close to 97%. And those studies say the last box over here, where they compared nasal to the nasopharyngeal, and in these two studies, the nasopharyngeal, so the nasal swab performed fairly well also. Saliva is something which I'm actually very excited about, which is not sputum, it's just spit, like you just thukofy into a bottle essentially. And this also has a fairly good sensitivity of 85%. Now saliva has other issues. Transport is the biggest one. That's why field mein karna mushkil hota hai, because saliva is full of bacteria, and by the time it comes onto the lab, there's a lot of overgrowth of bacteria. Then you may not get a good result. Magar, the residents know this. We've been piloting this in the inpatient, and we've had relatively good results. And then finally, mid-turbinate, this is pretty much like the nasal swab, and again, a very high sensitivity. Now, the nasal swab karne ka tariqa is different. You take the swab and you insert it about an inch into the nose on one nostril, and then leave it over there for about 10 seconds. Then you take it out, and then you put the same swab in the other nostril, about an inch. You wait for 10 seconds, and you take it out. So this is much easier to do. There's less aerosol generation, so there's infection risk बहुत कम होता है. You need less training, but patients can do this themselves. They don't have to have a person doing it. So in the coming weeks, we may see a change in how we're doing our diagnosis. The other diagnosis is antibodies, and this is probably one of the most common questions I get asked now. But please keep in mind, antibodies are not the primary means of diagnosis. आपकी diagnosis अभी भी PCR से होनी चाहिए. And the reason is that if you look at the dynamics of the antibody, you notice that the IgM initially, the earliest you're going to start seeing it is probably by day 7 or so of symptoms. But there are some studies where in hypertensives and elderly, the antibodies didn't develop till about 7 to 8 weeks after the illness. So we say that you cannot use the antibodies, and this is what is often asked. To confirm immunity. So अगर आपको antibody बन भी गई, तो you cannot say आपको दोबारा नहीं लगेगा. You just don't know what the reinfection rate is. We can't use the antibody to say that you're no longer infective. So even if you have IgG, you can't say that you don't have infective virus coming out. And then remember, antibodies will be negative in early infection. So antibodies do have a place maybe, but it's a very limited place. I would not use it as my primary method. And I usually would use an antibody if I have a very strong suspicion for COVID. Multiple PCRs are negative, and I'm using this for another way of confirming does this patient have the infection or not? Because sometimes the changes you'll see would be late in the disease, and this would be more pertinent, even more pertinent for the PEDS folks, for example, who see the multi-system inflammatory syndrome in the children, which is like Kawasaki's, and those tend to occur much later, not during the active infection, but much later. And then finally, sensory specificity vary. So जो kids हैं छोटे जो bedside वाले हैं जो field पे हैं, उनकी sensory specificity is pretty very variable. The one we do at AKU, I believe, is a total antibody which is a lot more sensitive than those. अच्छा, so अब diagnosis आपने कर ली, तो next step क्या है? You've got to figure out what the severity of the diseases, and इसमें बहुत सारे changes नहीं हैं. Albata, we try to simplify this a little bit more, and the classification is still the same. So asymptomatic, mild, moderate, severe, and critical. Asymptomatic is obviously no symptoms. There's no debate. Mild COVID is that there is no chest X-ray finding, and the saturation is more than 94%. Right, so 94 is a key number over here. Moderate COVID is the one just जिसके आपको hypoxia हो रहा है and your saturation is more than 90%, so 94 to 90% पे. And your chest X-ray has less than 50% infiltrates in the lung fields. So again, very subjective, but 50%, less than 50% involvement and more than 90% saturation. Severe it's when your saturation drops below 90%, when you have more than 50% involvement. You may be in respiratory distress. In fact, there was one patient we saw, I believe it was 2 days ago, who met the criteria for severe just because of the fast respiratory rate, and maybe in distress. And then finally, critical is obviously that's fairly straightforward. ARDS, multi-organ dysfunction, shock. People who are intubated would obviously fall into critical. So we've simplified these definitions a little bit more. The numbers to remember are 50% lung fields, 90, 94 for saturation. But what we've realized, or what I'm realizing now, is that there is a lot of overlap between moderate, mild, and severe. And you may see people who have like 50% involvement of the lungs, but clinically will fall under the moderate. Or you'll have mild patients who have no symptoms, but a little bit of infiltrate in the X-ray. So all of these definitions are not set in stone, and you do need to use your clinical acumen a little bit to decide which of these classifications the patient is falling into. And the other thing with the severity is obviously the immunity or the hyperimmune state. And this graph you guys have seen before from one of the earlier talks that are given. This means there are 3 stages: the early infection, the Fermi stage, and the hyperinflammation stage. And shuru ke dinon mein you have more of a viral response, and later on you have a host inflammatory response. And ye jo host response and this maladaptive response, this response which is too hyper for the body, leads to severe and critical disease in not all, but in a number of patients. And you can see the clinical symptoms which go with this. So shuru mein you have the mild cough and fever, but as your inflammation ramps up, you'll have more shortness of breath, the X will start worsening, and then eventually ARDS and shock. And the reason to put this in here is for you to realize that when a patient you see in the clinic or in the ward may show up as mild initially, but then progress to moderate disease. So these classifications do keep changing as you see in the patient. And we've had a number of patients who we first labeled as moderate, and then eventually 2 days later made labeled as severe, and vice versa. And the key thing over here is this point over here between the mild, moderate, and severe, is you need to catch this progression from mild, moderate to severe. This hyperinflammation is because of the cytokine release syndrome, the CRS, and this is the other thing to keep in mind. So first we talked about the severity, and the other thing you have to watch out for is the CRS, where you're seeing the hyperinflammation, and over here the goal is to reduce the inflammation in the patient. And we'll talk about how we do this, but we now have more definitions for CRS, and there are a number of definitions people have used. We had decided on this definition where you need to have a moderate, severe, or critical disease, so somebody who is probably requiring some oxygen. And with that, a ferritin of more than 1,000, which is rising over the 24 hours. Or a single value of more than 2,000 in somebody who is intubated or on high flow oxygen. The third criteria is somebody who has lymphopenia. So lymphopenia you would define as an ALC of less than 800, a percent of less than 20, which I find is the least helpful, or an NLR. So that's a neutrophil lymphocyte ratio. So you divide the neutrophil percentage by the lymphocyte percentage, and that should be more than 5. And you can imagine this means that you have a lot more neutrophils than you have lymphocytes, but which means that something's wrong, because in viral infections you obviously have more lymphocytes and not as many neutrophils. So you have to have lymphopenia, and with lymphopenia, any 2 of the following: a ferritin which is rising above 700 in 24 hours, an LDH which is rising above 300, a D-dimer which is over 1 and rising, and a CRP which is over 70 and rising. Now, if somebody has any of these 3, Nietzsche, A, B, C, D, on admission, you don't even need to document rising. I mean, that by itself is CRS. Now, these numbers are really helpful, but remember, these numbers have not been validated, and none of these things have been validated in large clinical trials. So these are a good guide for you when you're seeing patients to figure out कि अगर CRS हो रहा है कि नहीं हो रहा. We've treated some people with CRS when the numbers are almost at this level, and sometimes we ignore them when it doesn't meet the clinical criteria. But by and large, these work very well. So a ferritin more than 1,000 and rising, 2,000 ago ventilator ke upar hai. And then finally, a low lymphocyte with either a rising ferritin more than 700, LDH more than 300, D-dimer more than 1, or CRP more than 70. Keep in mind that these are all non-specific, apart from not being validated. Also that these markers don't rise at the same time. So sometimes you see a really high CRP and baki cheezein niche, sometimes a really high ferritin and baki cheezein niche. So they don't always follow each other. And I've also seen patients in these markers rise, but there's no clinical worsening, and those are the confusing ones. And we'll talk about some of these cases maybe after in the discussion. These markers are non-specific. Please remember, these are not COVID markers, and I've seen this sort of shift now towards using these markers to see agar COVID hai ki nahi hai. So, for example, a suspected COVID with a high CRP could simply be a pneumonia. Right, so these are non-specific markers and should only be used as a means of figuring out CRS hai ki nahi in somebody with established COVID. The NLR, especially the neutrophil lymphocyte ratio, may not be very helpful in somebody who's on steroids. So, aksar these patients on steroids. So once you start steroids, then stop following the NLR, because this will obviously, steroids will lead to neutrophilia, and your neutrophil lymphocyte ratio will rise automatically. In these patients, you want to look at your absolute lymphocyte count, which is a lot more helpful, and same goes in bacterial infections. So we talked about severity, we talked about the CRS, and the last thing you need to know before we talk about the management is the hypercoagulopathy that you see with COVID, because we have seen thrombotic events in autopsies. We know that there's a higher chance of VTE and DVT in these patients, and D-dimers by themselves are associated with mortality. And in at least 2 studies that I saw, the magic number was 6. So D-dimer more than 6 was independently associated with increased mortality. Unfortunately, we don't have very good high-quality studies of how to reduce the risk of hypercoagulability, and there are a number of different sort of guidelines or means people have looked at, and we'll go over some of these. But so the principle of treatment really is number one, supportive. That's the most important. That would include oxygen and prone positioning in people who are hypoxic. Anticoagulation is the second thing, which is either therapeutic or it's prophylactic. We have antivirals. There's remdesivir. Remdesivir is currently not available, but it should be here in the next 2 or 3 weeks now. You have the anti-CRS treatment, that's steroids and tocilizumab. And then finally, other immune therapy, that's convalescent plasma. And that's pretty much all we have currently over here. And now we're going to go over how we're going to be using this, and then use some real clinical cases for you guys to practice on. So, mild case mein kya karna? And this is a question that I get asked often. Ki agar outpatient mein patient hai to kya karne ki zarurat hai? So, mild cases are managed as outpatient, but keep in mind that in some cases we do admit these mild patients. So, there is a phenotype of COVID where there's a lot of GI problems, a lot of diarrhea, and these patients may need to be admitted. Sometimes the fever can be very high. We admitted somebody who had febrile seizures. And even though it was a mild disease, needed to be admitted. So not all mild is admitted as outpatient, but by and large, most are treated as an outpatient. For those who have a high risk of severe disease, and I was speaking to the other ID colleagues here at AQ, and we now have an unfortunate cohort of patients that we're following on phone and WhatsApp because they have mild disease. But what I do for people who have high risk of severe disease, so the elderly or those with comorbidities, is that I tell them to check saturations at home, and these little pulse ox machines, even though they're not terribly accurate, are really helpful. They stop. You don't have to have patients come to the hospital, and I just tell them to check the pulse ox machine, and the magic number I give them again is 94%. And the labs that I get done in them is just these 4, and this gives me a little bit of a feel. Or is that, are they going towards CRS or hyperinflammation or not? And that's a CVC, a CRP, a ferritin, and LDH. And this I usually would do again a little later in the disease. So remember, CRS develops usually in the 2nd week. So अगर मेरे पास कोई आता है कहता है कि 3 दिन का बुखार था, मैंने COVID कराया, positive निकला, otherwise तबीयत ठीक है, तो I tell them ठीक है, saturation check कर लें घर पे and just watch. But if they've had fever for about a week and symptomatic for a week, then I also get these labs done. And then if they're really markedly elevated and the patient's otherwise very stable, I still would sort of think about admission in these folks. And there is one patient who I was following as an outpatient and was actually getting a little better, but his markers went through the roof. And then we did eventually admit this patient, came under Nosheen service, and while admitted, the markers kept going up. The ferritins went up to, I believe, they were almost the 2000s. And then Dr. Nosheen decided to go ahead and treat, and the patient then also developed clinical CRS with hypoxia and lung infiltrates after that. Please no antibiotics. And this is probably the most common antibiotic that I've seen. Everybody's on azithromycin as an outpatient. There is no role of an antibiotic in a viral infection. So please, the old things that we've always said, that antibiotics don't affect viral infections. It's the same over here. Please not use azithromycin. There is also no role for using antibiotics to prevent secondary infections. In fact, now that our XDR typhoid season is ramping up, the amount of azithro that's being used in the community is really worrisome. And then, I'm all for Gheril Toke. I love My Haldi Doodh, I love Shahad, I love Adrak Ki Chai. But some of these Gheril Toke that are now coming up are a little dangerous. And the one that worries me the most is Sanamaki. And you may have, I'm sure you've heard of this. This is a tree. And this and you're supposed to drink a tea made out of the leaves of this tree, and this is the same tree or the same family of tree from which you get the senna chemicals for which used for constipation. So essentially, it causes diarrhea in a number of patients and can cause actually severe enough diarrhea for people to get admitted. So just be aware of some of these Gheril Toke. Yesterday I saw a WhatsApp message where people said that take Kalonji oil and something else, and you put in a nebulizer if you feel sick, and that's going to make you feel better, which just sounds really scary to me. What about moderate and beyond? Obviously you admit these folks, you give them oxygen therapy. I usually keep the saturations 94% or higher. Prone positioning really helps these folks, especially to get their oxygenation level back up again. And this could be awake proning or proning on the vent. When we talk about prophylaxis and we talk about thromboembolic prophylaxis, for moderate disease, all patients with moderate disease should be on DVD prophylaxis with enoxaparin 40Q 24 hours. However, some authorities, and we've also advocated this, that for severe and critical, we go to a higher prophylactic dose of 40 to 12 hours. Now, there are lots of algorithms out there also. Some use D-dimers and some don't. We had opted, given the lack of data, to just give everybody a slightly higher dose of prophylaxis in severe and critical. So that's the second thing to keep in mind. In labs, obviously the CRS markers, again, LDH, CRP, CBC, ferritin, and D-dimers every 48 hours or so, depending on how they're trending, and then other labs as is. So that's sort of your cornerstone of management. Beyond the prophylactic, sometimes we do need to use therapeutic anticoagulation, and there are 3 indications for this. If somebody has thromboembolic disease, so either on CT scan or ultrasound, if you have a very strong suspicion of thromboembolic disease and you can't investigate. So to give an example, the same patient I was talking about, the one who eventually developed CRS and was under Dr. Nosheen's service, I picked the patient up and the patient was doing better, but 4 days ago developed hypoxia, which was worse. So I was worried about a PE because he was almost now 2 weeks into the hospital. So I upped his enoxaparin to therapeutic levels while we got a CTPA on him, which did not show a PE, luckily. This is a more softer one, which is D-dimers over 3 times upper limit normal, which would be 1.5. Now, the exact cutoff can be debated, and we did debate this, and this was the consensus that had come out of it. But if your D-dimers are over 1.5 times, or sorry, at 1.5, then you may want to consider therapeutic anticoagulation. I don't always do this, especially if it's sort of low and the patient's otherwise well. But people who have really high D-dimers of 20s and more than 30s, I mean, for those, I will always give them therapeutic anticoagulation. The dose is your regular 1 mg per kg every 12 hours. And the duration is also something that we debated quite a bit. But generally, because we know this, this hypercoagulability state lasts for a little longer, 1 to 3 months is what we're recommending. We couldn't decide on if it should be 1 or 3. I prefer the 1 month, and we switched them to rivaroxaban 10 milligrams at the time of discharge. And if you have VTE, then obviously follow the VTE guidelines. So remdesivir, when we get it, now this one is a little theoretical. I haven't used it myself, but the indication is mild to severe COVID, regardless if there's CRS ongoing or not. And it's probably not going to benefit critical COVID because by then, you know, it's a little too late to use it. And in the Lancet study, they really, you know, the benefit was most in the moderate group. The dose is this, it's IV, and once we have it, once we have more experience, then, you know, maybe the next talk will have this incorporated in more. For CRS, you have 2 ways of treating it. One is steroids, and now we do recommend short and targeted therapy. And this means that the ideal time is when at the start of your CRS. So you have somebody who's coming in, जिनके markers अभी बढ़ रहे हैं, थोड़ा सा hypoxia develop है, that's the time to hit them on steroids. There's no role of giving it early. You know, if somebody comes to you with just fever and there's no CRS, do not use steroids then, because giving it early will really clamp down on your immune system, and there actually may not be much benefit very late in disease. And I know we use this in our ICU patients, but let's see what the data comes up to be. So, because for example, in influenza pneumonia, outcomes are actually worse, and I believe there was some initial signals that in COVID pneumonia, the outcomes may be worse also, which is why WHO had recommended not to use steroids in COVID. We use methalpred at 0.5 to 1 mg per kg per day, and the duration is 3 to 7 days. What I don't know yet, and we're sort of getting a handle of this, is should we change them to oral prednisone, or should we keep them on IV for 3 days? In the recent study, they only gave IV for 3 to 5 days, depending on severity. Over here, we've been switching people to oral, but I will tell you that on switching to oral, we do see a little bit of rebound hypoxia at times. And finally, you have tocilizumab, and this is only for CRS, and in those in the steroid they're not getting better. Yeah, they have really bad severe critical disease on presentation. Remember, it increases your risk of secondary infection. In our cohort that we've seen, the secondary infection rates were as high as 30%, including bacteremia and fungal infections, Aspergillus infections after tocilizumab. The dose is 4 to 8 mg per kg IV, and we don't give more than 800. And you can repeat it. This is often asked, but you repeat it usually at 12 hours if you see no response. I'm not sure there's much benefit repeating it much beyond that. This is the weight-based dosing, so we can save the vials. And IV हमारे पास खत्म होगी, but there is now we can reconstitute the subcutaneous as IV, and that's what we're doing. Remember, this has become a lot more expensive. The 1 vial used to be 50,000, and I believe now 1 vial has gone up to almost 2 lakhs as the demand has increased. So this has become more and more expensive as a therapy. Also, contraindications as expected with any strong immunosuppressives. The ones I just want to point out is elevated ALT and bilirubin, which sometimes precludes use in the ICU, and then a low ANC or thrombocytopenia. And then finally, convalescent plasma. We do have a trial ongoing. So, and the inclusion criteria is moderate to severe CRS. And then remember, you have to do blood grouping. And I usually use convalescent plasma in those who may not be responding, or I can't use TOSI because of contraindications. All right. So to sum it all up, and then we'll do some cases. So you have a patient fulfilling testing criteria. You do a PCR, and if the PCR is negative, then you may want to retest, may want to do an antibody if you have high suspicion. If your PCR is positive, then the first thing you do is you see ye patient kitna severe hai, right? For severity, it would be mild if there's no hemodynamic, DI, compromise, chest X are fine, and the O2 sats are more than 94%. And in these cases, you can treat them at home or an isolation facility like the Expo Center. If the patient is desatting or the chest X-ray is less than 50% involved, then this would be moderate, and these patients would be admitted to the ward. And then finally, if the patient's saturation is less than 90%, on room air or in distress or has ARDS, MODS or shock, and more than 50% involvement in chest X-ray, then they would be labeled critical and they go to the ICU. Treatment for mild is supportive care only, and call if there's any worsening. A treatment for moderate is oxygenation, prone positioning, and don't forget the inox at 40. And then for severe, it's the same, but a high dose of inox is used in this case. Remember, you may want to use convalescent plasma or remdesivir, and the benefit is probably more in the moderate or maybe severe, and maybe less in the critical, but plasma will be used also in critical cases. And then finally, keep an eye out for CRS, keep monitoring the markers. And if you do see CRS, you can use steroids, especially if it's early, and we found that's really beneficial, or use tocilizumab if it's severe. There are some unresolved issues, like what to do with isolated D-dimers. I saw one lady who had mild COVID, was admitted, but D-dimer was 1.5. I rechecked, it was still 1.5, but I didn't do anything else to send her home. I saw her in teleclinic on Friday last week, and she had a little bit of weakness in her leg, though her power was 5 by 5. Her daughter's a nurse, so she did the power was for me on camera, but her D-dimer is now to 4. And these sort of patients worry me that they may be at high risk of stroke later on. So what to do with these is a little tricky. Also, similarly, elevated markers, just when there's no, then the patient's not critical. So in these particular folks, generally I would ignore them and not do anything beyond it. Prolonged hypoxia is an issue, and then how long to treat patients with steroids. All right, so let's do some cases. And Iskender, what we're going to do is I am going to do I'm posting on the chat a link, so you guys can click on this link, and the link is right over here. Also, I'm going to give you a minute to sort of log in, and then the questions are going to pop up on your phone or on your screen, and then you can interactively answer. Let's see how we do. There's 6 cases. We'll see how many we can go through. These are all real cases. A number of these are currently admitted in the hospital. So we may not know what happened in the end. Some of them have gone home or gone elsewhere. And we'll start off with this just to give people time to log in and me to have a sip of my coffee. And I see the students are always faster in replying, in logging in. And if people have problems, we can always do this verbally also, but I think
प्रोफेसर ये एरर दे रहा है
क्या कह रहे हैं एरर पढ़ के बताएं ऐसा
Sir, he said this is a 404 error, which means you have clicked on a bad link or entered an invalid URL. May be what you are looking for can be found at bit.ly.com bit.ly links are
so your screen पे ना paulev.com/fmemo363 ये कर लो एक ही बात है
We have to go to another device to log on.
No, you can do it on your phone also. Sorry, on your computer also. That's fine. And this link will be there throughout, and you can log in a little later also. But I think we have enough people. So I'm going to go to the next question, which again is just a dummy question while people log in. So I just want to know what your current thoughts of COVID in the country are. And these are all the emojis that were going through my mind. Some people are crying. Most people are crying. Oh, everybody's crying. Some people are not saying very nice words, while others in shock. Okay, so all right, good. So we have 28, 29, 30, 31. Good. So we have a decent number of people who've managed to log in, and most people are upset. Some people are just rolling their eyes, while others are probably cursing a little bit with what's going on. Okay, good. So I think we're set. We'll do some of these cases now. Just give me a minute. All right. So the first case, and I'm going to go a little slowly to let you guys digest what these are. So this is a 75-year-old man. He had an RTA on the 5th, so 3 days ago. He had a femur fracture in multiple places and also fractured his ramus. Pre-op, and as you may know that pre-op we now do the PCR for everybody, and pre-op PCR turned out to be positive. He's saturating 98% on room air, and his only complaint really was pain in his leg. This is what his X-ray looks like, and I'll just leave this on for 2 minutes, or just a minute for you to take this in. So my question to you is, sorry, and his labs. So his counts are 7.5, 10% lymphocytes, CRP 238, LDH of 435, ferritin 322, D dimers are 26, and he's saturating, like I said, 98% or so on room air with this. So based on this, and I'll summarize, fracture, got a COVID positive, X-ray you saw right over here, and these are his markers. How would you classify him? Is he asymptomatic, mild, moderate, severe, or critical? So this is a good example of how it's not so easy sometimes when you're seeing patients to classify them based on their on where they are. And once we hit about 30, 35, I'm going to go on the next question. But so most of you feel this is either mild to moderate. Some say asymptomatic, and some say severe. So the answer, this was a patient who has asymptomatic disease, right? So incidentally, they found this COVID. And I'm going to switch. So what will you do with this patient? So this patient was asymptomatic. We luckily found the COVID in this person. One debate that we had was which I'm going to not mention right now, but okay. So most of you want to give, so some of them give steroids. Most of you are like, don't do anything. And I think the group is getting consensus because the steroid wale ab pareshan ho ke ja rahe hain. But nobody wants to give TOSI plasma to this patient, which is very reasonable because these have their own risk with them. So most of you, 80% want to do nothing, and that's the right answer. So this is just asymptomatic disease, and for this you don't, please don't give TOSI to this old man, whoever this person is. Say it. So, and what about anticoagulation? Yes, no, higher dose or therapeutic. D-dimer was 26. Okay, so most people want to not give anticoagulation. Others want to give prophylactic, usually at the normal dose, but some at a higher dose, and a few want to give therapeutic anticoagulation, probably looking at the D-dimer, which was very high. All right, so to summarize this one, I think, Iskandar, I don't have a follow-up. The others will have a follow-up what happened to the patient. So the answer to this is yes. The people who said 40 QD are correct. Remember, this patient had a fracture. He's immobile, so he should be on DVT prophylaxis. The reason why I did not give this patient therapeutic anticoagulation is, number one, this patient has asymptomatic COVID. Second, the D-dimer was elevated, but we know that D-dimer goes up in major trauma, which he had with this. So really, in this particular old man, COVID was not an issue. And in fact, his course is a little bit more rocky because, hey, you guys are changing your answer. So the course is a little bit rocky because after admission, his hemoglobin started to drop. And last night when the residents called me, it had gone down to 6, and we feel he may be bleeding somewhere inside. And hopefully, he's going to come out of this and have his surgery soon. But this was an easy case. How about this one? So 38-year-old man with history of fever and cough for 5 days prior to admission. He came to the ER with shortness of breath. His saturation was 91% on room air in the emergency room. He was put on oxygen. And this is what his X-ray looked like. So I'm going to give you a minute to think, look at this X-ray. All right. These are his labs. His counts were 8.4 with 15% lymphocytes. CRP was elevated at 164. LDH was increased at 422. Ferritin was 1200. I rounded it off so it's easier to see. D-dimer was 0.3 and his oxygen was 2 liters. Right, so somebody on 2 liters oxygen, this was the X-ray, and these are his inflammatory markers. So how would you classify this person's infection? Good, so half are there. Most people feel this is moderate, some severe, and then few people feel this is mild. The asymptomatic will look bhag gaye. Next, I'm going to hide the answers so you guys can't see each other's and then decide. Good, so 50 people. So yes, you guys are right. This is moderate. Remember, the saturation was between 90 and 94. The X-ray had about 50% or less involvement. So this is moderate. What would you put this patient on? Oxygen only, steroids, DOSI, or give this patient plasma? So only oxygen is a couple of people. Some people want to start steroids, or more and more people want to start steroids. So good. 50-50. कौन जीतेगा ये रेस? Oxygen steroids के दरमियान. It's neck to neck. Some want to give tocilizumab. And it's a 50-50%. So some people want to give steroids. Well, half want to give steroids, half want to give oxygen. So the answer here is, I'll tell you in the end what we did. About anticoagulation. None. Okay. So regular dose anticoagulation is what most people so far say, but only 12 people have answered. Good, 13, 15. Um, 28, 33, 34, 35. So most of you, by and large, want to give therapeutic anticoagulation. All right. So to summarize, this is a patient who had who has moderate disease, right? Because the saturations were between 90 to 94, but not below 90. He has CRS because if you noticed the and here right here, if you notice that the CRP was 164, ferritin was elevated. And the ALC was also low, and the LDH was also on the higher side. So the patient was in a cytokine release storm. So we opted to give this patient steroids, and over the next 2 days, his saturation dropped from improved from 2 to 1 liter to room air, and he was actually going to get discharged, I believe, yesterday when I saw this patient. And his inflammatory markers also, as you can see, the CRP dropped nicely. LDH started to drop. Ferritin usually drops a little late in this disease. And in terms of prophylaxis, because this is moderate disease, so remember, moderate disease will get just regular DVD prophylaxis. And these are his X-rays on the 4th and on the 6th, and you see nice clearing of his infiltrates on this. So this essentially was a patient with moderate disease with CRS, which we caught early enough that steroids helped him. How about this one? So 36-year-old man with cough, developed on the 27th of May. He was given a Sub-X-Z, vitamin C, and he took Sanamaki. He came with abdominal pain and vomiting on the 2nd of June. His saturation was 98% on room air in the ER. He had mild epigastric pain. Actually, was more, the residents at night said it was fairly severe, that they also got amylase lipase. These are his labs. From the 4th when he was admitted, his counts were 10 with 8% lymphocytes. So that would be about 8,000 would be, sorry, 800 would be the ALC. CRP was normal at 9.3. LDH was fine at 4.2. Ferritin was elevated at 1400. D-dimers were normal and he was saturating at room air. This is what his X-ray looks like. Give me a second. All right. I always shudder when I put the X-rays because I know that pulmonologist on the call. So how would you classify this patient's disease? So again, young man, abdominal pain, no desaturating, X-ray was what you saw, and markers I showed you those where pretty much everything is normal except for the ferritin is elevated. So mild, moderate, severe, critical, or asymptomatic. So most people feel this could be mild. All right, good job, guys. So yes, so this is mild disease. Remember, he's saturating well. His X-ray is okay. His lab's a little wonky, but otherwise he's okay. And his abdominal pain was actually the Sanamakhi that he was taking. He stopped it, and the next day he was much better. What would you do for treatment for this patient? But you know what? I'm going to skip this one. I just told you what I would do. Who owns shares in tocilizumab and steroids? Okay, so I understand. This is because of the ferritin. Okay, that does make sense. All right. So here's where things get tricky. So with this particular patient, an anticoagulation. Sorry, the next question, and then I will tell you what we did for this patient. So either prophylactic or none is what people are saying. Most people don't want to give any prophylaxis to this guy with COVID. And most people are correct. So remember, this is a young man, he's mobile, he has mild disease because the saturations were okay, X-ray was fine. So he does not need anticoagulation at this point. So we just hydrated him, we sent him home, he was stable, he had mild disease with diarrhea secondary to his herbal medicines. Unfortunately, on this at time of discharge, his ferritin went up to 2100, and this is where it gets confusing. You know, he doesn't meet the CRS classification. He's not hypoxic. He doesn't have any X-ray findings. The rest of his markers are absolutely fine. Just his ferritins are really going high. I did give him a call yesterday evening to see how he's doing, and he was doing absolutely fine. He's going to repeat his test today, and I'll see what it shows. But you know, I'm comfortable not giving him any medication and just watching him, given that he has a fairly benign course at this point. So remember, always treat the patient and never treat the labs. So 4 is a little different, and there's no graphs, so you got to type in your answer. So this is a 34-year-old man. He's a physician in another hospital, a surgeon actually. He developed fever on the 25th of May. He got his X-ray, and the X-ray did show some infiltrates bilateral. And a number of people in his department in the hospital, like all of the hospitals in the city, had people who were infected with COVID. So he got his SARS-CoV-2 PCR done twice at an interval of about 3 to 5 days, all outside AKU, and these were negative. He took azithromycin for 7 days because somebody told him this could be typhoid, and azithro is the antibiotic of choice for that. His fever didn't get better. He then took ceftriaxone for 3 days, 2.5 actually to be exact, and his fever still persisted. So he got admitted. We repeated his PCR ATU on the day of admission, and his PCR was negative. This is what his X-ray looks like, and you can see sort of subtle infiltrates bilaterally. And these are what his numbers look like. So his counts were 8.7, his lymphocytes 12%, so ALC was not terribly bad. CRP 63, mildly elevated. His CRP, so LDH was a little bit up. Ferritin, thoda sa, D-lam was fine. He was sitting on room air. Very, very, very anxious, more than anything else at this point. So what would be the next step? So here you got to type in. I just want to sort of get a feel of what you would do. So surgeon, history of contact obviously with COVID, has had exposures, has bilateral infiltrates, but 3 tests are now negative. Markers are not terribly bad and saturating fine. So what would you do? I can't see anything. So somehow I can't see the answers. So maybe you guys can speak up then.
Antibody testing?
Antibody testing. Okay, so that's one thing you can do. Antibody testing. Good. Anything else?
Testing through saliva.
Saliva testing. So saliva may not be as sensitive as as a nasopharyngeal swab. So what else? So what are the thoughts? What could this be? Is this COVID at all?
Can this be atypical pneumonia of some sort?
Yes, it could very well be atypical pneumonia or even bacterial pneumonia, post-COVID pneumonia, post-viral pneumonia. Atypical, I thought a little less likely because this patient had actually been on Azithro for long enough, and it's possible that this was pneumonia which was resolved, and we're just seeing infiltrates. All right, so I heard antibodies, I heard some saliva testing, some thoughts this could be a non-COVID issue, and one more thing that you could do. It's cheating. I haven't told you about it yet, but one more thing you can do. So good. So CT scan. Yes, a CT scan. So that's exactly what we did. We did a CT for COVID, which did show infiltrates just like you would see in COVID-19. We also did the antibody, and the antibody was actually positive for COVID. So this is probably this is what he had. He had a SARS-CoV-2 infection. And the PCR was missing it probably because of very, very low load of virus now in his respiratory secretions. And it so happened that he desaturated the same day. This is day before yesterday at night. And when you look at his markers, you can see that his CRP started ramping up. Also, his ferritin started going up as well. D-dimers a little bit also, and his ALC dropped over here. So we actually put him on steroids day before yesterday at night, and yesterday night when I got my follow-up, and I think my team is on the call and they can also give us a follow-up how he's doing today, but he was actually getting better. I did put him on antibiotics initially, thinking this could be a pneumonia, but once this came back, then I just stopped his antibiotics, and now yesterday morning he was back on 1 liter of oxygen. All right, last two cases, then we're done. So 55-year-old man who comes with fever and shortness of breath. Sorry, I can chat, I can see. So fever and shortness of breath in the ER on the 22nd. He in the ER he was hypoxic. He was put on BiPAP. We put him on steroids in the ER. The next day, blood cultures that have been sent were reported to have GPCs in them. And this is what his initial blood work looked like. So his, I'm sorry, I don't have the lymphocytes here, but his counts were elevated. His CRP was elevated. His ferritin was really high. His LDH was high. D-dimers we didn't have at that point. So this is what his X-ray looks like. It's fairly easy to see this one, the infiltrates, and clearly more than 50%. And how would you classify his infection? So most people feel severe to critical, some moderate. Luckily, nobody says asymptomatic, which would be sad. And then nobody also feels mild. So yes. So this would be severe disease, maybe even critical disease. But at that point, when he came to the hospital, it was probably severe disease for sure. All right. What would you put this patient on apart from oxygen, which is given? Steroids, plasma, TOSI, or none? So it's a little unfair because you can choose only one thing. So most people are debating for CRS treatment, which is correct, between steroids and TOSI. Some want to give plasma and not TOSI. Oxygen only, luckily nobody said. And Ali Aziz is cheating and giving the answer. All right, so the answer, so the answer is over here. is not TOSI. And the reason for this, which is in the chat, is that this patient has an active infection. There's GPs in the blood. So in a patient like this, you would not use TOSI, and this is a good patient for plasma, actually. What about anticoagulation in this case? So remember the role of anticoagulation, and we don't have D-dimers on him, but we have enough to make some decisions. Excellent. So most of you think, half of you or so have voted, and most of you feel that he should be on anticoagulation. The debate is higher dose prophylaxis or regular prophylaxis. And in this case, yes, because it's severe disease, I would use enhanced prophylaxis at 40q12. Unless there's some contraindication, there was none in him. I wouldn't give him therapeutic anticoagulation as yet because I don't have any evidence of a very high D-dimer or active VTE ongoing. So his blood cultures, steroids were continued, but he was intubated. We could not give him plasma. We didn't have his blood group available. And he was intubated. He went to the ICU. And blood cultures did grow MRSA. However, after 4 days of therapy with MRSA, and because he was not improving, we actually did eventually give him TOSI, and this was a little bit of a risky TOSI in some ways. His D-dimers were also elevated at 12.6, which is why then he would have then he got therapeutic anticoagulation. And you can see his CRPs started coming down with steroids at least, but his ferritin was still high and his saturation had not improved. He gradually improved after the TOSI, and he was actually extubated on the 1st, and he was shifted out to our service on the 4th. But before shifting out, he developed new leukocytosis on the 2nd with a worsening chest X-ray, and his blood culture lucent, which are now growing stenotrophomonas multifilia. And this is probably a consequence of being intubated along with being on antibiotics, which he should not have been on. And at the same time, tocilizumab, which reduced his immunity. So I added levofloxacin, obviously continued the vancomycin because of the MRSA. And actually, he was discharged on room air on the 6th. So he did very well, despite having severe COVID, being intubated, having 2 episodes of bacteremia. And we've seen this, that, patients who are intubated don't always die. And if we, when they cared for, some of them they do make it out. And our extubation rate is one of the highest in the country at about 50%, or a little bit lower than that. Higher than that. This is the last case, and then we'll open up for discussion. We're also running a little bit of behind time. So 41-year-old man with diabetes. He was seen in my teleclinic on the 3rd with fever and weakness. His saturation was 97% on room air. This is what his X-ray looks like. Leave it there for a minute. And then next, these are his labs, 7.6 counts, 13% lymphocytes, CRP 137, ferritin thoracobarabia, LDH thoracobarabia, D-dimers are fine, and he's on room air. What would this be? Asymptomatic, mild, moderate, severe, and critical. So 2 people voted, they are saying mild. Most people, actually, everybody's saying mild so far. So great, so you guys are getting a good hang of this now. In fact, nobody's saying anything else. I'm going to switch before somebody says something and I'll feel bad. Okay. So, so this is mild disease. What would you do with this person? Nothing, azithros, steroids, TOSI, or plasma. All right, interesting. All right, so most people have voted, and most people don't want to do anything, and that is actually the correct answer. Please, no antibiotics. This is not a bacterial infection. There's no role of prophylactic antibiotics either. You don't need to give anything. I would not use steroids. Remember, this patient is not in CRS. Please reserve steroids for patients who have the cytokine release syndrome. And these are often people who are moderately ill with arising markers. The patient is doing well, but still has low-grade fevers, and that's one issue we've seen. I have one person, he's a CEO of something, and he's now day 13 of his illness, and he still has fevers of almost 101, even though his X-ray markers and saturation are absolutely fine. So some people actually will have prolonged fevers in this infection. All right, so this is the last slide, time to wake up. A very one-liner summary. Remember, gold standard is still PCR. Antibody testing can be done in select cases. When you're seeing a patient, first look at the severity, then observe for worsening. Watch out for CRS. Remember, CRS means you have the two things you can use, steroids and tocilizumab. You can anticoagulate them if they're moderate or high, and the level of anticoagulation will depend on how severe the patient is. And that's it. That was my last slide. Thank you. And I'll hand it over to you now, Samar. Thank you.
Hello.
Dr. Faisal, can I ask you a question? Hello?
Dr. Faisal, your mic is mute.
I know, I couldn't find the unmute button. Yes, please.
Yes, Dr. Faisal Nanik here. And in your presentation, you didn't talk about the hydroxychloroquine. There's no word about hydroxychloroquine. And you know the controversy is going on and on about that. And recently the NEJM also retracted this article. And after that, WHO also started this trial again in selected centers. So can you comment on that about the use of hydroxychloroquine in COVID patients? And so far you have used probably in the early months of start of this COVID infection. How was your experience? Thank you.
So our experience with hydroxychloroquine was actually not too great. Anecdotally, really, we didn't see any benefit of using it. And we saw a lot of prolonged QT intervals with it. Lancet did retract the article, the last one on HCQ. However, the others have also not really shown much benefit with this. And, you know, none of us actually had enough compelling evidence to use this beyond in a trial setting, because really all the centers that have used it really didn't see it making much of a difference. Now, that doesn't mean there's no difference. It may be a very modest or small difference, but we now know that there are other things we can use which are working a little bit better. I do want to say that we're about to start enrolling in the Solidarity trial, the WHO Wali, and we will then be using this as part of the trial. But that will be a randomized control trial. So some people will get it, some people won't. And really that's the way to do it, because I'm really trying to move away from using, medicines where we don't know what, kifayda hota hai ki nahi hota. But you picked it up. I'm sorry, I should have mentioned. But yes, there is a lack of HCQ in my presentation now completely. Don't even talk about it. I have stopped talking about it now. There's a question by Sarah that what would you do if a patient with moderate or severe disease already immunosuppression like EZA and low dose steroids for other diseases that they had? So if they have moderate and severe disease and they don't have cytokine release syndrome, then I would probably increase their steroids to stress those steroids. But if they have CRS, then I would probably give them tocilizumab if I can.
Dr. Faisal, Dr. Javed, then Dr. Fawzia Siddiqui wants to ask a question.
Yes.
They have raised hands.
Yes.
Yeah. Faisal, thank you for your very comprehensive talk. I'm glad that you clarified the local totkas and regarding Sanna Makki, and I heard quite a few professors in medical profession recommending vitamin C, vitamin D, zinc, and Sanna Makki to be taken. In fact, one professor from USA who was in Pakistan before and now was advocating on a live TV program. So I'm glad that you clarified that. My question is that talking to you a few weeks ago, you mentioned that in order to release from the isolation, you need to have 2 COVID-19 tests negative 24 hours apart. Then you can declare them, fit for the society and they can roam about. But now we are seeing cases who are positive even after 6 weeks. I've got several patients who are COVID positive even after 6 weeks. Now, do you still hold that recommendation, or can we? It is so difficult to keep them inside their house and in the room for 6 weeks, especially someone is in working class. So can you please clarify those recommendations now?
Yes. So I'm glad you brought this up. I didn't talk about this in particular, but and when you say a few weeks ago in COVID years, that's like many years ago, it seems to me. because this talk I made also about a month ago for another presentation, and it's completely changed. But the answer to your question, Dr. Javed, is we now know that in most cases, by day 8, we have not been able to get live virus out in these folks. So even though the PCR remains positive, there's no live virus. And I'm just going to quickly share this screen over here, and you can see in this graph over here, this one right. And this is just one of a number of studies which have not come out. And I want you to focus, Nietzsche, at this positive culture, negative culture. So you can see the negative culture, even though the PCR keeps turning positive, by day 8, you were not able to culture any virus, which is we say that the indication to stop isolation is not based on PCR, but is based on symptoms. And if somebody has had symptoms for 10 days, it's been 10 days since start of symptoms, and at least 3 days since improvement of symptoms, right? So, so whichever is longer, you can stop isolation. And that's not what we've been doing everywhere. There are some exceptions. So immunocompromised folks, they may still have live virus for longer. And in those folks, we do want 2 negative PCRs. Healthcare workers also we were doing PCRs, but we've stopped that also. So the answer is no longer we do PCRs to stop isolation.
Thank you, Faisal.
Dr. Fawzia?
Yes, Dr. Faisal, thank you very much. A very informative talk, and thank you for clarifying a lot of misconceptions. There's still one misconception that we keep reading about, and that is the use of NSAIDs for the fever and headache in mild cases when they're at home, and especially the use of ibuprofen. And I noticed you did not mention anything on that, and how much and what's the maximum dose of paracetamol that they can take. And usually the cases with mild disease are not responding. Their headaches or their fever does not go down with paracetamol, and they want to take something else. And it's still controversial what not to take. Could you comment, please?
So to answer the question, amongst the antipyretics, paracetamol is still the safest, generally speaking, and the max dose is the same, which is 4 grams a day, and not more than in 24 hours. In terms of NSAIDs, I don't shun NSAIDs. So if somebody, this fever is not getting any better and they're very uncomfortable, then they can use an NSAID. But it's not my first go-to drug. We don't have enough data now to point that NSAIDs are bad. Keep in mind that whenever NSAIDs do have some anti-inflammatory effects, and obviously anti-inflammatory means they are immunosuppressive because inflammation is part of the immunity. We know, for example, that in community-acquired pneumonia, using NSAIDs increases mortality. Now, I'm not saying don't use NSAIDs at all; they're not contraindicated. But we start with paracetamol, and if they're still not getting control, then sure, Brufen, etc., may not hurt them, especially in low dose intermittently. I just want to sort of say also that there's this question about myocarditis, and Ali has mentioned that he's used diuretics, and yes, in ARDS to offload people, ICU's been using diuretics, and that has helped. I've also seen a lot of diuretic use on the floor, and I haven't mentioned it because I don't know what the outcomes are. The residents and I have been debating about it. But yes, in ARDS to offload definitely, and I haven't seen a lot of myocarditis, but I think there was 1 or 2 patients that we did suspect on. Somebody's mentioned procalcitonin. So procalcitonin is a good marker, especially before using to make sure secondary infections are near. A high procalcitonin makes me worry, but a normal one may still have infections, not 100% sensitive. But yes, we do check PCTs on these patients. Another question is troponin one of the risk factors of severe and moderate disease? Yes, it is. And this would obviously make sense given that if you have increased strain on the heart let's see, cytokine release storm seen in any other disease, are the hypoxia and chest findings analogous to non-cardiac pulmonary edema? seen in acute mountain sickness. so for this one, I'm going to divert this to a pulmonologist. But is cytokine release syndrome seen in other diseases? Yes, in many ways, an imbalance of your immunity leads to a lot of your manifestations in other diseases, such as even in dengue, the thrombocytopenia is because of your immune system. Do you see this degree of CRS? You do see them in other diseases, especially in the transplant world and also in the oncology world. And that's why we know about tocilizumab, because that's where we use them at. Anticoagulation, email, role of hydroxychloroquine.
Dr. Faisal?
Yes,
This session is about to end. We have only
Okay,
1 minute left. It will automatically end the Zoom session. Thank you, Dr. Faisal. Thank you very much. Thank you, everyone.
All right, thank you.
Okay. Allah
Thank you,
Hafiz.
Hafiz.